I call upon the next presenter, Dr. Apurva BANSOD, Capsular Convexity and Capsulorrhexis Challenges in Intumescent Cataract, post NDR glazer as AIOS2025. Over to you, Doctor.
Good morning, everyone. I'm Dr. Apurva. I'll be presenting our work on intumescent cataract. With the pioneering future, we are pioneering the future with next-gen technology, but still operating on an intumescent cataract poses a challenge for all of us. In spite of multiple difficulties, the real challenge lies in making a good capsulorrhexis. There are multiple studies which prove that NDR anterior capsulotomy is highly effective and safe. Now, when we did it in our center, in some cases we found excellent results where there was significant flattening of the anterior lens surface. While other cases, like this case of Morgagnian cataract, we didn't find much difference. Now, this led to a research question, what are the anterior segment parameters which will affect the outcome of the NDR glazer, and what are the intraoperative challenges in these cases? It was a prospective interventional study. We included 90 patients who were diagnosed as intumescent cataract on slit lamp. We excluded patients for whom we were not able to take a good scan, posted for femtosecond, any complicated surgeries, or if there was a capsular fibrosis noted. We did preoperative biometry scans for all of them. Now, on ASOCT, the patients were classified into 4 groups based on the IOCT classification given by Dr. Titya et al. Group. So here, if you see, this is the type 1, where there are regularly arranged lamellar cortical fibers with very minimal clefts. This is type 2, where the clefts have increased and there are continuous hyperreflective bands of hydrated cortical fibers. Going to type 3, these clefts join together and forms a homogeneous ground glass appearance along with intralenticular clefts. Finally is the type 4, where it's a uniform homogeneous appearance of the anterior lens cortex. Now, after classifying these patients, all of them underwent an NDR glazer capsulotomy almost half an hour before the surgery, and we targeted areas of fluid. And post-laser, the ASOCT scan was repeated. Now, on ASOCT, we looked at the following parameters. One is the crystalline lens rise, that is the distance between your the line joining the angle recess and the anterior lens surface, the anterior chamber depth, and the front radius of curvature of the anterior lens. So these are our results. This is a patient showing pre and post YAG. So if you look at the anterior curvature, it has flattened significantly. Now, this difference was clinically, statistically significant, especially for group 2 and 3. Similarly, if you look at the circumferential lens rise, pre and post YAG, it has decreased from 1263 to 613. And the difference was significant, again, in grade 2 and 3. Similarly, the anterior chamber depth increased. Now, when we did a multiple regression analysis, we found 3 factors which were clinically which were significant. One is the lens thickness. So when you compare, a 1 mm increase in lens thickness caused a CLR change, that is the effect of YAG, increased by 26 micron. The cataract class, as we saw, type 2 and type 3 gives you the best results. And third is the pre-CLR, that is the lens rise. A 100 micron increase of CLR caused an effect of 13.7 micron. In coming to intraoperative challenges, we reported no cases of Argentinian flag sign, posterior capsular rupture or nucleus drop, and in all patients the lens was implanted in the back. This comes to our conclusion that preoperative OCT helps us in classifying and planning a cataract surgery. NDR glazer capsulotomy is highly safe and effective. We reported no complications. And the 3 factors which affect the outcome is the lens thickness, the grade of cataract, and the circumferential lens rise. Thank you.
Doctor,
sorry, please.
What is the time gap you give between doing the laser and taking up for surgery?
So we keep at least 30 minutes, max 30 minutes, because if you go beyond that, that causes edema and that can affect you because
Correct.
the fluid comes out. And if there is a lot of egress of fluid, that can affect your visibility.
IOP also can go
Yes,
up.
sir. Yeah.
So 30 minutes is the upper
30 minutes is the max, but we try to shift the patient as fast as possible.
Tell me, what did happen? This has been done earlier also. What was the What is the originality in your study?
So, sir, here we try to find out, we don't need to yak all INTMAT patients. So for us, ASOT scans are generally uploaded on this. We see the scan, we see the, as I said, the 3 factors which affected. The lens, we look at the lens thickness on ILMaster or Argos. We look at the grade of cataract. If it's a grade 1 or a grade 4, I will not send my patient for the yak. Third is your circumferential lens rise. So as I showed the graph, here you can say ki if my CLR is almost 1000, I know how much effect I can expect.
So how do you choose your patient in which you do a YAG, or you only do a needle capsulotomy, or do maybe a femto capsulotomy?
So if it's a femto,
so do you make a choice between the 3?
So if the patient has opted for femto, on Catalyst the incisions are so fast that you won't need a YAG capsulotomy. And also if you have done a YAG caps, the fluid comes out, and then the femto will not help because that will obstruct the energy. Second thing is we look at the ASOCT scan, sir. Depending on, we have not compared other methods with anterior capsulotomy. What we found is these patients do better. It's a preference choice, but saying in favor of capsulotomy, it's a closed chamber. Second thing is, if you look at INTMAT, there are 2 spaces. There is the anterior and the posterior compartments. So if you're doing a spiral Capsulorrhexis or any on table, you are decompressing only the anterior compartment. So in NDR capsulotomy, you do decompress the anterior, but by the time the patient is shifted to OT, the equatorial barrier between the lens anterior capsule relaxes. That breaks the barrier between the cap, and that way the posterior compartment also decompresses.
What is the percentage of cases you do in this, and what would you do it only? What is the percentage of cases in which you do anterior capsulotomy this way? Generally.
For few surgeons, few surgeons prefer YAG capsulotomy. So based on ASOCT scan, we post them for, we send them before surgery. Others have different techniques. So
in
that's
your
surgical
study,
preference.
how many you had to take up for YAG capsulotomy, and how many you had to
so
just
we
decide
diagnose them on INTMAT. We diagnose them on slit lamp. If we are seeing fluid clefts and if they have been diagnosed as INTMAT, we took all of them for YAG so that we know which patients do better. Now, if you see type 1 didn't do good, or there was not much significant change.
So in your study, all cases you did
All INTMAT cases we posted for YAG.
Thank you.